Welcome. It's so exciting for us to have come to the end of the first cycle of our Women's Giving Circle and to be hearing today about the researchers who are going to receive funds from all your generosity. I'm so pumped to hear these folks talk, and I'm sure you are too.
I'd like to start off by welcoming everyone here today. Along with Mrs. Shirley Abramsky, our honorary chair. We are so delighted to see everyone here today. And thank you so much for your support over this last year. We're here because you have put your trust and confidence in the Women's Giving Circle, and we're just so excited to see the first annual awards funding come to fruition. And again, it wouldn't be possible without you, so thank you so much for your support. I'd just like to thank you. I'd like to start off by introducing to you the executive from the Women's Giving Circle. And if the members wouldn't mind just standing just briefly. Shirley Abramsky, who is our honorary chair. Kathy Burke, who is our vice chair, and she'll be joining me during the presentations this afternoon. Evelyn Maison, who's in charge of finance. Your money's in good hands. and Marcia Shannon, our secretary, and she keeps us on track. She runs very efficient meetings. Carol McKillop is joining us here today as well. And Spurla Anagnostopoulos is here. Mary Lapierre. Carol Davey. Lillian Carmel Marcus, and Jillian Little, although she wasn't in the brochure, she's part of the executive. So thank you to the Women's Executive for helping to shepherd us throughout this first year. I also wanted to give a special note to the members from the University Hospitals Kingston Foundation. They have worked tirelessly for us in the background, helping to organize all of these events, been facilitating the research process as well. And I'd like to especially acknowledge Lori Fagiani, Jacqueline McMurray, and Joanne Metcalf. And Denise Cumming as well, who's been our supporter right from the beginning. So please join me in thanking these ladies for their tremendous efforts during the year. I'm very pleased to report that we now have over 60 members in the Women's Giving Circle, but Shirley has challenged us to go up to 100. So our work's not done, but we have developed a great process for the circle. And if you know of anyone who is interested in joining, please let one of the executive committee know. We're pleased to go out and talk to groups. We have brochures, and we would just be very appreciative of the extra support in the membership area. This year in the Women's Giving Circle, we developed an annual format for the group to follow, and this is the way it's going to roll out. So in the fall, we'll come together for a luncheon, and we'll select an area of research to fund for the coming year. We will be inviting a speaker who's going to provide us with educational knowledge about what it's like to actually be a researcher, what are the challenges, the pitfalls, and how their area of research contributes to the overall healthcare system. So that will be our fall luncheon. Then Dr. Daly's office will go away, and they will put out their call for research proposals and also organize the peer-reviewed process so that we follow in step along with the existing hospital system. In the wintertime, we plan to organize a behind-the-scenes tour to one of the laboratories in the hospital or in associated areas at Queen's University. And we hope to put together a tour that is seldom experienced by others in the community. So this past February was our first attempt, and we went to the Human Mobility Motion Lab at Hotel Dieu. And for those of us who were part of that tour, it was very, very interesting and was a wonderful opportunity to speak directly with the researchers and see their excitement and their visions for the future. It was a great tour. And then in the spring, we'll come together just like today, and we will award the funding for the year and also invite the researchers who are the recipients to talk a little bit about their research areas. So we think that this format is something that everyone will enjoy and learn, and we can come together and be inspired about what's great about our community. So just to close off that piece, I'd like to thank everyone once again on behalf of the executive, and offer out, does anyone have any questions, or at any time if there's any suggestions that you have for us, we'd be pleased. Okay, all right, great. 100% of our funding is actually going directly to medical research, and that would not be possible if it was not for the sponsorship of Shoppers Drug Mart. And Rena Acheri is here today to say a few words, and please join me in thanking Shoppers for their support of this endeavor.
Thank you, Mark. So on behalf of the 11 stores in Kingston, I want to thank the University Hospitals Foundation for the opportunity to support this amazing group. It's exciting and inspiring as a woman to see all of your efforts come to this day. I think we started about a year ago, and it's amazing to see this. The Women's Giving Circle is a unique fundraising initiative, and it's right in line with Shoppers Drug Mart's focus on women's health. We support quite a few national women's health organizations, but for myself and the other store owners, we're always really enthusiastic to support our local hospitals and university. I'm the only female store owner in Kingston, but none of the other ones want to come because they're usually pretty intimidated by you guys. But, I can tell you that they're all enthusiastic supporters, so thank you so much.
Okay, so now's the fun part. Now we get to award the money and learn a little bit more about the research. So our first presenter is Dr. John Muscadere, and I'm just going to read you his bio, which is also provided for you in the luncheon package. Dr. Muscadere is an intensivist at Kingston. I'm sure that doesn't mean you're intense. Okay, we're going to find out what that term means as part of the talk today. He's at Kingston General Hospital, and he's also an associate professor of medicine at Queen's University in Kingston. He's in the intensive care unit, the research director at KGH. He is the co-chair of the Canadian Critical Care Society and the Canadian Critical Care's Trial Group and Clinical Practice Guideline Committee. He's the Local Health Integration Network Critical Care Leader for the Southeast LHIN. I know we're in good hands if we need anything in critical care. Anyway, please join me in welcoming Dr. Muscadere.
First of all, I really am appreciative to be here, and thank you for funding some of this research. I'm predominantly a critical care, so I'm a critical care physician, and what I do is clinical effectiveness research, or that is where we look at different therapies and compare whether one is more effective than other. Do clinical outcomes research where we take new therapies and then see if they improve outcomes. This is part of a research program that we're just starting up, and before I talk about our research program, I'm going to just discuss what intensive care is and what critical care is. That comes from the intensivist part. So I'm going to talk about critical care research. This project that we're doing is called Outcome Priorities and Intensive Care Studies, with the acronym of the OPTICS program. Maybe I'll do that. So what is critical care? So critical care is a specialty that deals with patients who have life-threatening illnesses, and which is usually practiced in intensive care units. These are wards within the hospital that are able to provide specialized services. They have close monitoring. They have life support technologies that can temporarily replace or support failed organs, and we can administer potent medications that can't be administered anywhere else in the hospital. So just in the context of why critical care is important from a healthcare perspective, in Ontario, over 140,000 patients are admitted to ICUs per year. 66% of all patients admitted to ICU are over the age of 60, and over 20% are over the age of 80. So we're becoming more and more of an older specialty as the population ages. ICUs are incredibly expensive, and they've been estimated to cost 0.5 to 1% of the gross national product, just spent on a small area of the hospital which may not have very many beds. And ICU beds are in short supply, and this is going to become an increasingly big problem in the future. Why do we need critical care research? Well, so admission to ICU is associated with high levels of mortality and prolonged illness and disability. It's worse in the older population. ICUs were originally designed to support patients with rapidly reversible, life-threatening illness, but that's not becoming the case anymore, and that's changing. And a lot of patients are being admitted to ICUs at the end of their lifespan where the underlying problems or conditions are no longer reversible by admission to ICU. And this is becoming an increasingly big problem. So these are the challenges and where I think critical care research can address them. So critical care is increasing demand, as I said before. There's going to be about an 80 to 100% increase in the number of critically ill patients over the next 20 years, and demand will overwhelm capacity in the next 10 years unless we do something to alter that curve. And critical care, in spite of how much we actually spent on it, is not well understood or known. There's little understanding among the population and among physicians, for that matter, of what critical care can and cannot do. And it's got a very low profile. So more people die in ICUs than die from heart disease, but yet heart disease and all those other things have a much higher profile. And we need more research. We need better therapies to improve the outcomes of those that are critically ill. And we need to better define who and who will not benefit from ICU admission. And the biggest thing that we need to move towards is towards patient-centered outcomes. And we need to understand what patients and citizens value in regards to critical care outcomes. And we need to more broadly educate about the benefits and downsides of this expensive resource. So my research, or this small area of research, is going to focus on understanding what patients and citizens value in regards to critical care outcomes. And why it's important to engage people. These are some quotes from the Canadian Institutes of Health Research and from the Public Health Agency of Canada, that citizen-patient engagement ensures that funded research reflects the needs and values of Canadians, and public involvement complements scientific research and can now actually help direct it. And by doing this, we can improve the relevance and translation of research into practice and policy. We can contribute to more effective health services and products, and we can improve the health care system. So this is so I'm going to spend the next few minutes discussing the specific research study. As I said before, it's called the Optics Program. So it's a program of research studying the preferences of patients and citizens in determining outcomes for critical care trials. The broad term for this is called integrated knowledge translation, and it's becoming an increasingly larger focus among public funding agencies. So just to back up a bit, so how do we define citizens? So citizens are defined as people from the lay public who have not had a recent life-threatening illness and have never been admitted to ICU, and patients are defined as people who have had a recent life-threatening illness who have been discharged from ICU. So the citizen engagement, that's how CIHR, Canadian Institutes of Health Research, defines integrated KT. And we want to use citizens and patients to help select outcome measures for our critical care trials that we're doing. These are the clinical effectiveness research that we're conducting. And why are we doing it in the ICU? Well, surprisingly, it's never been studied in critical care, and it's been studied in other fields of medicine. It's studied predominantly in chronic illness research, but it hasn't been studied in critical care because critical care sometimes is felt to be too complicated. And traditionally in critical care, one of the things that we've always done in critical care research is looked at mortality as the main outcome. So all our trials have actually been designed to look at who survived more. But that may be not the major thing of importance, and we want to look at that. And it's sometimes felt to be too difficult. So in other words, our overarching questions are, Is survival at all costs, should it be the main driver of any treatment decisions we make? And as I said before, traditionally mortality has been the main outcome in critical care trials. Other questions, would a therapy that was associated with a reduced chance of survival but better quality of life be acceptable? And underlying that is, how much of a mortality difference would be acceptable for a given increase in quality of life? So here we're trying to balance trials and therapies that may actually not even change mortality, but one may have a better quality of life, one a reduced quality of life. And how do you actually balance those things? And that's one of the things we're going to be looking at. And finally, the last question is, if our therapies do not impact on the chance of survival, there are other considerations that we need to take into account. Should it be quality of life? That's just one of the things. What if one type of disability, well, how do we trade one type of disability for another? So for example, one of our critical care trials, one therapy may be associated with increased chance of stroke, but reduced chance of renal failure. Which one is more, or increased chance of renal failure? Which therapy should we use, or vice versa? And these things have actually never been vetted through. Researchers have always powered their trials based on these things, based on the opinions of researchers, but we've actually never gone out to citizens and patients to discuss these outcomes. And so, and importantly, our overarching question is, how do we choose which outcome is most important? And patient and citizen engagement may be one of the ways. And our overarching research question is, do patients and families have different priorities for outcome assessment in critical care research studies as compared to clinicians and researchers? We're going to do that by recruiting 4 groups. One group is going to be patients or ICU survivors, which we're going to do from people who have participated in our research studies in the ICU. We're going to recruit a second group, where these are citizens or lay people who have not been in the ICU, and we started recruitment for that already. We're going to recruit a group of clinicians and researchers and a group of decision makers. These are people who have decisional authority in critical care. And each group, we're going to train each group, and then we're going to have consensus building processes to rank outcome preferences using structured scenarios, and see what each group would prefer as an outcome in critical care trials. So that's basically it in a nutshell. I've gone through a lot of things, but I'd like to thank you again for sponsoring the research and for listening to me. And if anybody is interested, as part of my recruitment, to be part of the citizen group, please contact me. There's my email. I'd love to have you. I'd love to have anybody. We need to get to that 50 patient level. Thank you again.
Our next recipient is Dr. Michael Rauh, and he is a new clinician scientist in his second year of appointment in the Queen's Department of Pathology and Molecular Medicine at KGH. He was born in Sudbury. His journey to Queen's involved undergraduate biochemistry studies at Laurentian University, a master's degree in medical sciences and breast cancer research at McMaster, and a combined MD, PhD training at the University of British Columbia, including leukemia research at the Terry Fox Laboratory and of the BC Cancer Agency. So please join me in inviting Dr. Rauh to the stage.
Marg, and thank you everyone for attending today, for the invitation to come and speak with you. And I'm a relatively new clinician scientist at KGH. I'm very appreciative of this funding opportunity. It's going to be very critical for me to help get my lab off the ground. And I like your logo, by the way, so I tried to incorporate the color. So I have 75% protective time for research, and 25% of the time I wear a hat as a blood pathologist. So I'm able to see the current state-of-the-art in pathology, yet I have a real window on what's emerging and what's tremendous potential coming down the pipeline. So what I'd like to talk to you today about is my goal to detect cancers earlier, in particular the types of cancers that I look at as a blood pathologist. And I'm showing you here a microchip where we're moving from. We're not going to replace the traditional microscope, But we're moving towards doing things on microchips as well as a complementary platform. So new tools that are going to be coming available to pathologists. So in the few minutes, I'd like to provide you with an overview of what is myeloid cancer. So to tell you about how they arise, and to tell you about the limitations of current practice. And I'm really excited to tell you about the project that's been funded by your Giving Circle, and how it might lead to an impact of earlier detection and more personalized diagnosis on the road to more personalized medicine. So as a blood pathologist, I study the blood cells. And there's three main types of blood cells. There's red cells that carry oxygen. There are platelets that help to clot your blood. And then there are white cells that fight off infection. Although these cells circulate in the blood, they don't last forever. And so, for example, red blood cells last for about 4 months. But the other cell types are lasting on order of only a few days. And so we need to constantly replenish these sources of blood cells. And that's done in our bone marrow. So in the middle cavities in our bones in our body, where there's still a little bit of bone, but there's more of this liquid material. And in essence, if you will, the bone marrow is a factory that is constantly churning out the blood cells that go into our circulation and replacing those cells that die off. And this is accomplished by a remarkable type of cell called a stem cell, which is the most immature cell in our body. And it's thought, we don't know exactly, but it's thought that we have only several hundred to maybe a few thousand of these in our bodies. Yet these few thousand cells produce billions upon billions of cells throughout our entire lifetime. And so they reside in the marrow, and they're constantly producing the mature cells that we see here. And they're very rare. They only occur at about 1 in 10,000 cells that we would look at under a microscope. Yet they stay with us throughout our life, and they're very important to maintaining our blood counts. Now, as we age, those cells start to incur damage and to their genetic material. And normally in our body, we have the ability to repair some of these damages that occur. But eventually, we can't keep up with every mutation that occurs. And so myeloid cancers arise when these stem cells get mutated. And this leads to, if we're using the factory analogy, they start to pump out goods that aren't quite ready for the production line, and they're defective. There are three main types of myeloid cancers, which I'll just briefly describe to you. There are myeloproliferative cancers, myelodysplastic, and acute leukemias. And those are in order of severity. It's not too hard to diagnose. So I'm showing you here that the lightning bolt is a mutation, and then this leads to the cancer. The other two are not particularly difficult to diagnose, but the one that I will really focus on today is myelodysplastic syndrome, which is quite difficult to diagnose. And there is possibility of intervening earlier, because often MDS will progress to full-blown leukemia. And so it's poorly understood, difficult to diagnose, yet if we could understand it better, we might prevent the more severe types of leukemia from occurring. It's a relatively common cancer in older adults. For example, it rises to greater than 20 cases per 100,000 over the age of 65. Survival is hard to predict, but it can be very short, from just a few months to up to 5 years. And so we really need to do a better job of understanding how the different types of diseases that people get. Unfortunately, the only cure is a stem cell transplant, but most elderly patients aren't suitable for this risky procedure. And so it's not very satisfying, but most of the treatments now are supportive. They're patchwork treatments. They're not getting at the actual root cause. And it often requires blood transfusions, which can be problematic. Now, it is fairly common, but we think that it's actually even more common and underdiagnosed. About 2% of adults older than or equal to 65 years of age have significant anemia. Now, the family doctor will work up this anemia and often find causes such as iron deficiency or other nutritional deficiencies. But about 1/3 of these anemias are unexplained. And what we think, I don't have time to show you today, is that about 1/3 of these are likely due to MDS that isn't being diagnosed. And so in fact, with some of the statistics performed with my colleagues at Sunnybrook in Toronto, we think that it may be 10-fold higher prevalence of MDS than we suspect, up to 0.2% of the population over or equal to the age of 65. Now, this is sort of a cringe-inducing diagram, maybe not. So I left out some of the gory blood tubes, you know. I know it's lunchtime, but right now, the way we investigate it involves an invasive procedure where we have to go into the bone marrow and take out some of the material to analyze it. So you can imagine this is an uncomfortable procedure. There's great anxiety. Patients have access to the internet and they read about this, and so this is the way we need to get samples to diagnose MDS currently. However, the way we diagnose this is fairly antiquated. Like I said, I'm a researcher. I'm seeing the promise, but I think we have to catch up to the promise. So right now, a lot of it depends on subjective criteria under the microscope. I'll say that cell looks abnormal. A colleague of mine next door may say, I don't think that's an abnormal cell. Really, that's not the way we want to be diagnosing this type of cancer. We can do genetic analysis, which is a low-resolution karyotype, but at least half the time it's not contributory. And currently there are no specific gene mutation tests that exist. But there are some promising research advances. So where can we improve? Well, right now, because of what I told you, these problems, it takes about 2.5 to 3.5 years on average to diagnose this. Yet on the research side, if we look when cases are called normal by the traditional cytogenetic means, that up to 70% of patients have mutations. And these are thought to arise well before any microscopic changes occur that I would see with the visible eye. So let me just show you a time frame of how we think MDS evolves. And over on the right side of the screen, we have MDS in red. And in order to diagnose it, we have to have these funny looking or dysplastic cells and find an abnormal karyotype, which we don't often find. But we believe that there's a stage leading up to this, which we're not yet detecting, where there's suspicion, but we're not meeting the criteria. And in fact, we believe that mutations that we can look for will be the first event that we should be able to detect on the road to this early detection. I will just briefly describe for you that in order to do this, we want to look at a panel of about 20 mutations, which is fairly manageable. But if we did this with traditional means by PCR, this would require hundreds of individual tubes and would be very labor intensive for the technologist, very expensive. And it's not a very sensitive test. Now that chip that I showed you on the introductory slide, so this is a really exciting development. This is something called next generation sequencing. And we don't really require a lot of upfront processing. And in fact, millions of different sequencing reads can be conducted on this little chip that's about the size of your thumb. It's much more rapid and sensitive than the traditional means. So this is the technology, which is called the ion torrent sequencer. Just showing you what it looks like here. This is we have this in kgh, and this is not to scale. The chip is much smaller, but we basically load the chip with the patient samples and plug it into the machine. And then the machine sequences the DNA strands, which I show on the right, and it spits out sequence information. Now this requires these powerful instruments because what we get are little wee bits of sequence, which if you imagine are tiles, let's say on the floor. And so these tiles will overlap each other, and we'll compare it to the reference genome sequence. And what I've highlighted for you here are two areas where there's a change from the reference. And so where there's a change from the normal reference genome sequence, that's called a mutation. So we aim to apply this test to 3 sets of patients. There are those who have already been confirmed as MDS, who a few months previously I'd seen their bone marrow and we couldn't quite pull the trigger on the diagnosis. We were suspicious, but it didn't meet that. Moving back in the pipeline, we'll look at older adults with abnormal blood counts, especially unexplained. And even further back, we'll get a sense of how frequent are these mutations in healthy adults with no blood count abnormalities. So let's call these A, B, and C. On the bottom, I'm showing you the traditional pathology diagnosis. And what we'll be doing on the top with the funds from this, that you've provided, is to look for these molecular barcodes, these mutations. So in A, where patients have progressed to MDS as our control, and then looking back even further with the assistance of some of my clinical colleagues who will be providing samples to see if we can find these mutations earlier on. The potential impacts are to develop a less invasive test. I showed you that cringing bone marrow biopsy photo. So hopefully we wouldn't even have to do the bone marrow biopsy. We could just sample blood and find these. With greater sensitivity and providing more objective and personalized criteria. And we really need to begin to understand how common are these mutations in healthy adults, sick adults, and then those with the disease, so we can begin to predict who we'll have to watch more closely, who we may have to intervene with. And the other impacts are that we'll understand the disease better, and when we can target these mutations, that becomes a guided missile, if you will, a more personalized therapy. And I'm part of, there was a question earlier about disseminating the knowledge. So I'm part of a Canadian MDS consortium. And in addition to providing updates to the Women's Giving Circle, part of the plan built in is to disseminate this knowledge to other pathology departments, to other clinicians, so we can implement practice changes. So I'd like to thank members of my research laboratory and some of my colleagues at Queen's Pathology who are important contributors of this genome technology, and Dr. Sudeep Gill at KGH in St. Mary's of the Lake, who we hope to collaborate with once we've developed this test, to apply it in these patient populations, and some other collaborators at Toronto who will provide further patient samples. So I thank you tremendously. As I mentioned, I'm a new investigator, and these funds, I'm very excited to get going with this research. Thank you.
Our last recipient is Dr. Anna Johnson. Unfortunately, she was not able to be here today, but I'll just read you her bio. It's very impressive. She's actually a Canada Research Chair in Health Policy and an Associate Professor in the Department of Community Health and Epidemiology at Queen's. Dr. Johnson is also Site Director of the ICES at Queen's Health Services Research Facility and a member of its Pharma Epidemiological and Economics Research Unit. I think I almost got that word. She is a scientist at the Institute for Clinical Evaluative Sciences and a senior scientist in the Division of Cancer Care and Epidemiology. She's also a Queen's Cancer Research Institute at Queen's University. And presenting today will be Dr. Zhan Xu on behalf of Anna Johnson. So please.
Hi, thank you very much for the opportunity to be here today. Unfortunately, I don't have any audio, visual, anything dazzling to show to everyone, but thank you very much for the kind introduction and for the opportunity to be here today to share with you our research on the topic of new blood thinners for the treatment of atrial fibrillation. And as introduced, my name is Zhan Xu. I'm unfortunately not a doctor yet. I'm a medical student here at Queen's, and it's a privilege to be here today, so thank you. Atrial fibrillation is a common heart condition whereby the top two chambers of the heart, or the atria, do not pump properly. And it's a relatively common condition affecting about 350,000 Canadians, 3/4 of whom are aged 65 and over. It is also very costly. Over $800 million are spent in Canada each year on the care of atrial fibrillation patients in the form of hospitalizations, emergency room visits, and surgical interventions. One of the most feared complications of atrial fibrillation is the development of a clot that can travel to the brain, causing a stroke. But this can be effectively managed and prevented by the use of blood thinners. On the other hand, because you're making the blood less clottable, if you thin the blood too much, you get the adverse effect of the drug, which is major bleeding. One of these blood thinners is called Coumadin, or warfarin, and many of you may have heard about these. And it has been the therapy of choice for the past 60 years. In the last 3 years, though, we have seen an emerging number of new blood thinners that have come onto the market, and many of you may have heard about these as well. It's called Pradaxa, Xarelto, or Eliquis. And these newcomers have expanded the choice that physicians have in preventing strokes in patients with atrial fibrillation, which is quite positive. However, we know from medical literature that patients that we encounter in daily clinical practice, such as you and I, may differ from the participants of randomized clinical trials in which new drugs are tested. A trial for a diabetes drug, for example, may exclude, say, a patient who had had a prior heart attack, even though we know from clinical practice that these two events may coexist in the same patient in reality. With respect to these new blood thinners, we have shown that within 2 years of their introduction in Ontario, that they have been prescribed most frequently to the very elderly, aged 85 and above, in whom the risk and benefits are continuing to be debated. One additional consideration is the fact that while bleeding caused by warfarin or Coumadin is reversible by a variety of agents, the same cannot be said for these new blood thinners. This has resulted in continuing discussion in the medical community about the use of these new agents in patients with atrial fibrillation. Our study seeks to provide evidence to help address this uncertainty by evaluating the use of blood products and healthcare resources, as well as patient outcomes in individuals who present to the hospital who are on a blood thinner who has experienced a bleed, comparing between Coumadin or warfarin to these new agents. Here at Queen's, we're the first satellite site of the Institute for Clinical Evaluative Sciences, and this allows us to combine the hospital-level data that we gather locally with the population-level data gathered provincially, providing us with an important tool to answer the questions that we have proposed. We have a fantastic team led by a group of clinicians and scientists, including Dr. Anna Johnson, that has been introduced, and as well as Dr. Chris Simpson. We have been fortunate to receive some funding from the Canadian Institutes of Health Research for our project. However, in the current funding climate whereby the amount awarded to each successful federal research grant falls 20 to 25% short of the requested budget necessary to carry out the research, your support and investment at the local level will be essential in our ability to conduct research with the highest scientific rigor so that we can provide an answer with confidence to these big questions. And in so doing, we hope to provide evidence that will transform and improve the care we provide to the 350,000 Canadians living with atrial fibrillation each and every day. So on behalf of the grant team, please accept my most sincere appreciation for your investment and, more importantly, for your faith in our research. Answering questions on health that matter to Canadians is what motivates us each and every day, and admittedly, many late nights when we have to stay up and write our proposals. And we very much look forward to, in the near future, to sharing with you the outcomes of our research and its impact. Thank you again for your support.
It was amazing. The research was just so interesting to learn about, and it's going on right in our own community. And again, the pooling of our funds has really helped to foster these research fields, and it's just really exciting to see it come to fruition. Before we close off, Kathy Burke's going to say a few closing remarks. I just wanted to thank Dr. Roger Deely on behalf of the Women's Giving Circle, because he's been with us through the beginning and helped us design a process that would work well with the hospitals and in keeping with what the membership for the Women's Giving Circle would like to see. So Dr. Deely, if you could just stand up for just a moment, and we'd just like to thank you for all your support over the years. Okay, Kathy, thanks for support. Kathy Burke will now close off the meeting. Thanks, everyone.
I have to say, what I was most excited about today was the spectrum. Marg talked about the rhythm we have decided upon for this year and that we fell into, which was in the fall selecting a research area, and then in the winter going and doing tours, and then in the spring being able to award funding based on the entire process. And in the fall, last fall, we all got together, if you remember, and what the group wanted to fund was research on aging. And what I thought today was how incredible the spectrum is that would encompass aging. So we learned, we heard from 3 very different types of researchers, right from the microscope to outcome research, which isn't the same kind of thing, and it all has to do with aging, and it all has to do with making our lives better when we do age, hopefully, or make us not age as quick, or maybe not age at all. I don't know whether you've got some of those. I didn't hear anything about the Fountain of Youth, but that's what I think was most incredible. So I just wanted to thank the researchers again for coming and sharing that with us, because that to me was a huge education on its own, is really how broad everything is. So thank you very, very much for that. This weekend, I don't know if everybody had an opportunity in the newspaper, and we talked about it at our table actually, because Kathy was in the newspaper, but there was a section on the nurses and their 125th anniversary. I think they're having big parties this weekend. And that brought to mind I don't know if anybody noticed, but there were an awful lot of women in there. All of it was women.
And you know, I started to really think about the impact women have had on supporting healthcare, and it's from professionals who took it up as an occupation. And in this, you know, it's sort of, in the modern world, and I find myself doing the same thing, you don't remember all those things. There are lots of men nurses now. There are lots of women doctors, women researchers, but it wasn't that long ago that women played a very different role in healthcare. Some of them took it up as an occupation and was professional, but a lot of it had to do with volunteer work. All the hospital auxiliaries and foundations were, you know, a lot of that work was done by women. And I think, you know, our group is sort of another milestone in that kind of thing, and I think that that's also exciting in that sort of journey of women supporting healthcare in a different way again. You know, a lot of us are professional women that are not in healthcare. I would never have been able to say 3/4 of the words that you are always saying. But you know, the fact that you're able to come together and support healthcare, I think, is a really interesting evolutionary step for the whole journey. So I wanted to thank everybody for coming. Today we have members in the audience who have joined the group. We also have guests of members in the audience that hopefully today you are really inspired to join. One of the things we have for members, and you know, I don't know if you know this, but we do have a job description for members. And I hope everyone who's a guest would like to join and become a member because of this job description. Of course, you have two jobs as a member. One is to select the research funding to be able to fund the great work that's going on. But the other one is, and this is, Mark sort of alluded to the fact that Shirley wanted to get to 100, but she actually has a strategy. So the other job that you have to do is, as a member, we'd like you to bring one more person to the group. All we need is all 60 of us to bring one more person to the group. Will way exceed Shirley's expectations by 20%, if my calculations are right. I may not be a researcher, but I do know numbers. So we could exceed that in no time at all if all of our members could bring one person. So that's your job. And better than anything that, I don't know if you've been reading the paper too, that, you know, the bank executives get lots of money and they get big bonuses and all that kind of thing. We have something that's much more exclusive, because as a member, you will get this t-shirt. The CEO of RBC would love one. Can't get one, first of all, because he's a man, although we would take his money. And certainly if you're a member and you don't already have the t-shirt, you want one, so please let us know. If you're a guest and you want a t-shirt, you must become a member. Last time I wore this, but it didn't match my outfit today. Thank you very, very much for coming. We're going to see you in the fall, hopefully. New members will be coming. Hopefully the guests will become members. I think the next meeting is October 8th, so there'll be more information about that. Because we've got our sort of rhythm going, we'll be able to publish dates a little bit in advance compared to this year where we were still learning the ropes ourselves. So we'll see you all, I hope, on October 8th. Thank you very, very much.